Three, two, one. You can start now, man.
Good evening to all. We are here again after 3 weeks for another masterclass by Abha ma'am. And today the topic ma'am is going to talk about is very important in our day-to-day practice, which is an individualized embryo transfer. So over to you, ma'am.
Thank you, Bhavani. And I wish there are some more participants because this is a very IVF related talk. So I know that a lot of gynecological clinicians may not be interested in the talk. It may not be very pertinent for a lot of gynecologists who are not practicing IVF. Yet, if there are enough IVF people, I would love to share what I know about this. And when we say individualized embryo transfer, when did this concept come up? It only came up after the birth of Louis Brown. Why? Because we then understood that we can take a egg, make an embryo, and put it in the uterus, and it will implant. So uterus implantation factors make it implantable, and the embryo is a separate entity. And then came up our Subhash Mukhopadhyay's baby, which was a cryopreserved embryo, which was again transferred into a woman's uterus after 57 days. So this is where the concept that endometrium grows in a different mode and might be different from how the embryo has formed. So the progression of technology, first we started after baby Louis Brown and after baby Durga were born, conventional stimulation protocols and fresh embryo transfer is what we all did in 1990. When I started, this was how we started. It was all long protocol. It was a standard dose 225 of gonadotropin, which was given at that time. Also, we like to use Metrodin, which was pure FSH urinary, though. And we always did a fresh embryo transfer. And there were standard doses for all. We didn't have AMH. So it was just FSH age, and our dose was almost constant 225. But then we had a lot of OHSS, a lot of multiple pregnancy rate because we did transfer 3 embryos, day 2, day 3. That was the highest we could go up to, and lower implantation rate and hence pregnancy rates also. Then came the era of individualized controlled ovarian stimulation. And here we looked at the previous stimulation, the age of the woman, her ovarian reserve, her antral follicle count, and then we individualized the doses and the protocol for every woman. And we tailored it as per patient profile. And if we thought that we've stimulated the patient a lot and there is likelihood of OHSS developing, we also learned to freeze all embryos. This started around 2011-12. So it made ovarian hyperstimulation syndrome happen minimally. We had better implantation rate and pregnancy rates, and we had lower multiple pregnancy rates. So individualized control ovarian stimulation is still the word for the word go for any stimulation. Then came the era of individualized embryo transfer. And during the discussion that I want to speak on individualized embryo transfer came up another word, personalized embryo transfer. And I thought personalized is different. Only in repetitive implantation, recurrent implantation failure, we use that word. But no, they can be used interchangeably. However, individualized embryo transfer is as per the woman's health and her implantation window. And it aims to safeguard women's health and also gives us the highest pregnancy rate. So these are the two aims of individualized embryo transfer. And so what is conventional embryo transfer? OCR, oocyte recovery, followed by one or multiple embryos transferred at any stage of development in a fresh cycle, which has just undergone controlled ovarian stimulation with the aim to achieve early and highest pregnancy rates, despite whatever health risks are there. We always did a fresh transfer. We do a fresh transfer in conventional embryo transfer. What is individualized embryo transfer? Definite number of embryos, whether they are fresh or frozen, to be transferred in a woman, not only with the aim of achieving the highest chance of pregnancy, but also to minimize health risk in all respect to the woman. So this is the aim of individualized embryo transfer, and hence now it is becoming very important. So there is no possibility that one size fits all, neither in when we do an individualized controlled ovarian stimulation, similarly not in individualized embryo transfer cycles. Now I have questions for the audience, and I wish there is a chat box where I cannot find a chat box anywhere. Can you just bring the chat box in front, Bhavani?
Chat box is
And
there, ma'am.
okay, you'll
I'll
start.
convey the
So
answers.
I want all the audience, whoever can think, right? At least write 1, 2, or 3 conditions where you would prefer only single embryo transfer. I mean, conditions in the woman or embryo or wherever you think. Just write in the chat box. I'm giving you some time to think. 3 conditions where you would want to prefer single embryo transfer. Excellent. Neha's phone was Mullerian, unicorn with uterus, good quality embryo. Well, low BMI. Okay. Medical disorders like cardiac, Mullerian anomalies, very good previous LSCS. I'm so happy that you all have brought in all this. So we will put together all these when I come. Now the next question is, can you minimize the chat box? Oh, I'll have to do it only. No, I don't know how to do it. Okay, 3 conditions where, can you read the question, anyone? I
3
have,
conditions where you prefer single embryo transfer.
yeah, now start with
This is done.
messages. 3 conditions where you would prefer fresh transfer. 14 new messages. Oh, great. Okay, I'm sorry. I'll go back. So, how do I remove this box from this blessed screen of mine? Is there any way? So just read out what everyone has written.
Ma'am, just click on the slides where you can see the slides in the small box. Just click on it, it will enlarge.
Where I can see the slides. I can't see the slides anywhere in the small box.
Acha.
How do I get rid of this blessed?
क्योंकि हमें आपका full screen दिख रहा है.
Okay, ठीक है. So what was the question? Say again.
3 conditions आपने बोला where you prefer fresh transfer.
Yes. So, Suma, why are you writing risk of OHSS, PPOS, and need of PGT? How can you prefer?
Ma'am, actually जो slide में question आ रहा है ना, वो आ रहा है 3 conditions where you would avoid fresh transfer.
Yes,
Question जो slide पे आ रहा है.
Yeah, that is what I'm asking. 3 conditions where you would avoid fresh transfer. So I think very good. Donor cycle first transfer. Let's read all the questions. Asynchronous endometrium at risk of OHSS to avoid fresh transfer, raised progesterone, very good. PGT, risk of OHSS, PPOS, need of PGT, excellent answers. Then the third one comes in. 3 conditions where you would only do frozen transfers. Come out with answers. I love your answers. Very good. PPOS, OHSS, high E2, oncofertility, PGT. So I'm glad that you already know what is what I'm going to talk about. But yeah, I have to remove this blessed thing from my desk. How do I do it? There has to be some cross somewhere, no? Okay, I'm shifting it to a side. Gone. Okay. So conditions which warrant only single embryo transfer, like you all answered. Uterine malformations, uterine previous surgery, maybe it's adenomyomectomy or myomectomy, especially large ones if cavity is open. Previous obstetrical complications, we'll come to this. And one child already present is a question mark. But we would want, a lot of parents only ask for a single embryo transfer if they already have one child, because the norm is these um, norm for these couples is that they just want 2 children and not more. And conditions which do not allow fresh embryo transfer, you all answered very beautifully: risk of OHSS, progesterone elevation, inappropriate endometrium, and medical conditions peri-COS. Say patient's got acute appendicular pain while she's undergoing COS, or she's got a lung infection, or she has fever or dengue or COVID. We would never want to do a transfer if she's suffering from medical or surgical conditions. The last is conditions which warrant only frozen embryo transfer. We'll justify all these. Non-synchronized donor-recipient cycles, you've already told me this. PGT, you've told me. Displaced window of implantation, yes, that is in recurrent implantation failure. This is the place where we term it as personalized embryo transfer in recurrent implantation failure, and previous ectopic and IVF cycles. I'll justify all these. So when we start off, we say conditions which warrant only single embryo transfer. Generally, all indications safeguard the woman's health. It is just to safeguard the maternal health, to some extent the fetus also, but it is mainly all in favor of the woman. And that is why uterine malformation, especially unicornuate or bicornuate uterus. In septate uterus, there's not so much difficulty, but a unicornuate or bicornuate uterus generally is known to be half the uterus only. And if you place an embryo, preterm deliveries are common over here, and distension of the uterus with a twin pregnancy might peril the woman's life also. Then uterine surgery, whether it is myomectomy, adenomyomectomy, previous hysterotomy with a longitudinal incision, all this only allows us a single embryo transfer. Then any obstetrical complications, especially when there is a miscarriage in second trimester, cervical incompetence, especially a preterm delivery with a twin where both the twins had not survived, a single transfer is a must. We cannot risk the patient again with 2 embryos transferred, whatever stage of development they may be. And if one child is present, the request for one child from the couple comes in. Then conditions which do not allow fresh embryo transfer. What are the conditions? All indications either safeguard women's health or optimizes our chances of pregnancy. So these are, now there are 2 reasons why which do not allow fresh embryo transfer. Either they will safeguard a woman's health, or they will give us a better chance of implantation and a live birth. What are these 4 conditions? One is underlying PCOS, pre-HCG, high E2 levels, and if the trigger is given, the risk of OHSS. So this is now becoming the most important indication where we do not allow fresh embryo transfer if there is any risk of OHSS. I mean, in some centers, especially in my center, sometimes even with 10, 12 oocytes recovered, a high E2, maybe the fort and foy is low for the patient, but she's got stimulated ovaries with good E2 levels, we avoid doing a fresh transfer. Number 2 is progesterone elevation. Now, while I was writing this lecture, I thought of a very interesting thing, that when in frozen embryo transfer cycles, we give exact 5 days of progesterone. And if you give 6 days or 7 days, the implantation may not happen. Similarly, if progesterone, and then it has been known that basal progesterone should not be more than 1.5 or at the most 2 when you start a cycle for FET, whether it is natural cycle or a HRT cycle. What is the aim of this? That we don't want longer exposure to estrogen, especially if it was low earlier and starts rising with stimulation. And then what happens? That as it rises on the day of HCG, it has gone above 2.5 or 2.25. Here, the endometrium is being already exposed to progesterone, and the changes of progesterone effect on the endometrium have started 2 days earlier. So by the time you do a transfer, it will be 2 days advanced. And this is the reason in progesterone elevation early on the day of HCG, we find poor pregnancy rates. And this happens with stronger and longer stimulation for IVF. We'll come to a little detail about this later on. Then inappropriate endometrium on the day of egg pickup, you find oh, the endometrium is looking very thick, or it's looking very thin. It was all right earlier. Or there is a big polyp sitting over there, 1.5 centimeters, which I missed out on day 2 or 3. Or you find that the patient is already bleeding a little bit, or you find a lot of fluid in the cavity. So all these things make you unsure about the implantation effectivity in this patient, and you always try to postpone, freeze all embryos and say, I want to look at this endometrium once again, I want to treat it, and then I would do a transfer. And last is, as I told you, any medical surgical condition which arises during OCR or around that time, you might still pick up the eggs and then leave the patient to be treated medically or surgically uh, for being cured, and then transfer the embryo at a later stage. So when we talk about, can we really predict the risk of OHSs? Yes, we can predict to some extent, but some girls with even lower estrogen levels, lower number of oocytes, with HCG trigger can land up into OHSS, and very few patients with very high E2 levels being given a GnRH agonist trigger also can sometimes land up into early OHSS. So what are the prediction factors? You all know, a young woman, thin built, underlying PCOS, high AMH, previous history of OHSS, serum E2 high, in IVF more than 2500, in ovarian stimulation more than 1200, and multiple stimulated follicles around 20 mm. So these are the factors which will predict, but what will trigger it off? The HCG trigger. That is what is the trigger to say that yes, OHSS will happen. And if you can predict in all this, you avoid giving HCG. And what do? You segment your cycle in 3 steps. First is that you know that this patient had a previous history of OHSS. You give her an antagonist protocol, give her slightly lower dose than what she got, give her a shorter stimulation, and that's it. Then you give her a GnRH agonist trigger. Don't try to transfer your embryo in that, freeze all, and then you can transfer in a later on cycle, whether it is HRT or a natural ovulatory cycle. In both, you will have a good pregnancy rate. So ovarian hyperstimulation syndrome is purely clinician-created iatrogenic life-threatening condition which occurs in absolutely healthy young women desiring to have a child. So we have to understand, we are doctors. We cannot create such situation in patient where they are fighting for their lives. They are admitted in hospitals with very high treatment, multidisciplinary treatment being offered to them to just save their lives. So no fresh transfer in these COS cycles where you think even there is a small chance that they will have OHSS. And then you have 2, 3, 4, 5 days to think about it further. So if you think that maybe, you don't know whether she's going to have OHSS, estrogen levels were 2000, you did give a HCG trigger, and you think you may want to do a transfer, she made a poor embryo, you have 5 days to follow up the patient, look at the ovarian volume, look at free fluid, look at her symptoms, and please do not try in a hurry to do an embryo transfer on day 2 or 3. Take the embryos to day 5, and if she has slightest symptoms of OHS, you can still postpone by freezing all her embryos. Then comes progesterone elevation. I already told you what was in my mind. And while looking at this, I also looked at levels of progesterone. Do the levels of high progesterone also make the window, change the window of implantation? But I couldn't find that evidence anywhere. You give 4 sources of progesterone, you take serum progesterone to as high as you want, but it is the length or duration of progesterone exposure which makes the window of implantation open up. And all the evidence says which supports altered endometrial receptivity with progesterone elevation in late follicular phase in controlled ovarian cycles for IVF. And elevated serum progesterone, as I told you, may be associated with diminished implantation and live birth rate in fresh embryo transfer cycles only because progesterone exposure has gone beyond 5 days. And the changes, secretory changes, started much before the egg was retrieved and the embryo was formed. Now, with the development of IVF, we learned that embryo and endometrium are 2 different entities. They they are dependent on each other in most of the natural pregnancies. But when a pregnancy does not happen, it could be that the embryo is running a different uh, um, lifespan and a different development age, and the endometrium may not be fit for that embryo age from the same patient from in the same cycle. And what did we find? They can develop in two different directions. What has given us this knowledge? COS can render endometrium appropriate for implantation while still generating perfect quality oocytes. First proof of endometrium being independent of oocyte formation came alive with the development of oocyte donation IVF program. That we thought we are developing eggs from another patient, taking the eggs, making an embryo with the husband's sperm, and putting it in another woman and developing her own cycle, whether it is natural or HRT dependent on just the progesterone we are giving her. Then Diostim came in, where luteal phase stimulation gave us perfect oocytes and embryos, but the endometrium was nowhere appropriate for implantation. And then COS for IVF with progesterone being used instead of GnRH analogs to suppress LH, that is the PPOS program. Hello, it is the PPOS COS, where we saw that we still generate perfect oocytes and embryos, but progesterone is high, and this endometrium is absolutely unfit to implant embryo. So what are our concerns? Premature rise of progesterone in late follicular phase with COS for IVF cycles is a frequent event, and especially in patients where high degree of stimulation is given. And it cannot be prevented by use of analogs, may they be long agonist protocol or short antagonist protocol. It occurs with normal LH levels without premature luteinization, and it is only caused by, I would say, ovarian overstimulation or hyperstimulation. Incidence is almost 40% of all stimulated cycles, where we would have minimalized all the pregnancy rates of these women if progesterone really rose to higher levels on the day of trigger. Independent from the protocol used for stimulation, several publications describe the negative impact of premature progesterone elevation on the outcome of ART treatment. Impact of high progesterone levels on embryo implantation, because progesterone exposure targets the endometrium, causing its accelerated or disc synchronous. I wouldn't call it disc synchronous after I read this article again and again. I just feel it is accelerated. We expose the patient to progesterone 2 days before even the eggs were retrieved or ovulation happened. And this has been confirmed by histology and by gene expression profile. I will give you an example of a patient of mine where 2 embryo transfers failed. Very nice blastocyst. And I thought, she's a young patient. She should have, there's 60% chance that she should have got pregnant. So she needs to go through a ERA test. We did a ERA test after 5 days of progesterone. They said, give 1 day less. I gave 4 days of progesterone. They said, give 1 day less. When they said third time, I said, no, I'm not agreeable to this. If we are transferring blastocyst, I can't just give her 3 days. I mean, 4 days may you say give her less, that comes to 3 days. And if in 3 days you say give her less, it'll come to 2 days. How can this be true? I will not give 2 or 3 days of progesterone to transfer a blastocyst. It will not work. Then what happened? That report was sent to Spain. And the person over there said she's being exposed to progesterone somehow earlier than what you think you are giving her exogenous progesterone. Please do her progesterone. We did another cycle. She was on HRT. Acha, we didn't do another cycle. In the same cycle, she was still continuing on HRT. She was on estradiol valerate, 3 tablets a day. We did a progesterone level and we found it was 6.2 nanograms. So possibly she always had an escape ovulation with whatever HRT we were giving. And hence every time her progesterone exposure we thought was 5 days, or second time we thought is 4 days, third time we would have thought is 3 days, and still they are saying, no, window of implantation is already closed. She needs even lesser progesterone. So even on HRT cycles, I have now learned at this age of mine that doing a progesterone before starting progesterone may be a very valid indication of giving progesterone replacement in HRT cycles. So this was a very nice article I found on Reproduction Biomed online. And it said the abstract is elevated peripheral progesterone levels in late follicular phase seem to affect endometrium and window of implantation, which may lead to asynchrony between endometrium and developing embryo. In stimulated cycles, endometrial maturation is advanced on the day of oocyte retrieval. Already, the progesterone effect has come on the endometrium. With progesterone levels of above 1.5 nanogram at HCG trigger, causing alteration in endometrial gene expression profiles on day of final oocyte maturation. This progesterone level seems to represent the critical threshold at which a negative effect on the ongoing pregnancy rate in fresh IVF cycles can be observed. So this is for fresh cycles. But even in the HRT cycles now, I have learned my lesson now with this patient that so I had these questions in mind. Day of exogenous progesterone exposure should be equal to embryo age. And if by any chance it is more than the embryo age, it would be out of phase. But then I had these two questions also, and I went through a lot of papers and I couldn't find that do serum levels of progesterone also matter when people give a injectable, a vaginal, a oral, or a dermal also? And would high dose of progesterone also lead to a displaced window of implantation in FET cycle? So these two questions go unanswered for me. I could not find anything related to this. I would want all my audience, which is so well read and is doing so much work in IVF, to find if really very high levels of progesterone, serum progesterone, could also displace the window, or it is only the duration of exposure. So progesterone elevation before ovulation makes the endometrium significantly advanced. And I would say any cycle with elevated progesterone over 1.5 to 2.5 nanogram per ml before trigger or ovulation is not appropriate for embryo transfer. At least fresh embryo transfer should not be done in these cycles. So if you are contemplating a fresh embryo transfer, then progesterone levels are important. If you already, your patient is hyperstimulated and you're thinking you will do freeze all, or there are other reasons for freezing the embryo, you don't need to do a progesterone level at all. Endometrial defects. Now we come to the third one, where I said at the time of egg pickup, you find that the endometrium is not looking good. It is very thick or thin. And you think, no, it was not like this when I saw her last time or whenever. Or you suddenly find a small polyp or a submucous myoma protruding out. You might withhold your transfer unless the polyp is very small. You find there's bleeding and there's loss of endometrial thickness. In this case, nobody would ever do a fresh transfer. And you find a lot of fluid. Now we find little fluid, we ignore it also. And sometimes we give antibiotic for endometritis, but a little fluid is in order in the endometrial cavity. A nice thick endometrium might have a little fluid, but if there is enough fluid and there is a connecting hydrosalpinx, it is better to withhold your transfer and freeze the embryos. So you have to treat the defect medically or surgically before transfer. Once you freeze, you see what is the problem, put in a hysteroscope and try to treat. It's very important that if you find fluid in the endometrial cavity and you do a hysteroscopy, please take a biopsy and write to the histopathologist, look for plasma cells in my biopsy. And if there are such, and you think there could be a chronic endometritis, treat her for 2 to 3 weeks with either erythromycin or doxycycline. You might find some changes in the endometrial cavity next time. Now, freeze all strategy and cycle segmentation, this comes as the last thing, that when you freeze all, in all these indications, what you do, whether it is progesterone elevation, OHSS, or you find the endometrium not appropriate, in all these conditions, and the last one was a medical condition suddenly arises or a surgical condition arises, you freeze all. So you are very happy that I've segmented my cycle, and I'll do a individualized ET in a subsequent cycle. But please remember, freezing and thawing might induce epigenetic alterations in key genes and transcripts. Such modifications might have long-term consequences for the child conceived after frozen thaw embryo replacement. We are yet to see the first and second generation of these babies born out of frozen thawed embryos. So always keep fresh transfer also in your armamentarium. Don't give it away in this era where vitrification has become so popular that a lot of centers tend to only do freeze thaw cycles and no fresh transfers. So an alert should always be there when we say freeze all. Having said that, I come to the last condition, conditions which warrant only frozen embryo transfer. So all these indications, like I told you, first one was where only single embryo transfer was indicated, were mainly maternal safety conditions. Then we came to maternal safety conditions, where we said that don't do a transfer in the fresh cycle. Now we come where only frozen embryo transfer should be done. All indications optimize chances of a normal live birth. So conditions which warrant only frozen embryo transfer is PGT embryos. You all gave this answer. Non-synchronized donor recipient cycles. Excellent. This was also a answer given by all my delegates. Embryos or oocytes frozen for fertility preservation. So this is one more additional answer. I didn't see this. Maybe somebody may have given. But if you frozen oocytes for either social reasons or fertility preservation, they all will always undergo IVF ICSI, and these would be transferred um, only as frozen embryo transfers. And then displaced window of implantation, especially in recurrent implantation failure. And a very important indication is previous ectopic in an IVF cycle. Now, previous ectopic in an IVF cycle warrants a little talk on it. I'll come to that. But rest, you all understand that there is no question about PGT embryos have to be frozen because we have to wait for the PGT report. Non-synchronized donor-recipient cycles, there's no way out except freezing these embryos. Embryos or oocytes which have been frozen earlier will be a frozen embryo transfer only, where the oocytes have to be injected, fertilized, and then transferred, and embryos also which have been frozen in women who already had partners will have to be thawed and transferred. So I'll talk about these two last indications. Now, recurrent implantation failure and displaced window of implantation. What is recurrent implantation failure? Till now, we always took Wilhelm's definition, 2014, that failure to achieve a clinical pregnancy after transfer of at least 4 good quality embryos in a minimum of 3 fresh or frozen cycles in a woman under the age of 40 years. 40 years. And when these were euploid embryos, then we said 2 good morphology euploid embryos. If they fail to implant, then it is considered as recurrent implantation failure. Now, this is across the board. Across the board, we say this is what should happen. But then people did not agree. They said, how can you have one definition for a 25-year-old, a 40-year-old, 45-year-old? No, we will change it. So I'll come to the recent definition now. What is displaced window of implantation? We must know what is window of implantation to know what is displaced window of implantation. Window of implantation may a period ranging from 1 to 2 or up to 3 days when endometrium becomes receptive for implantation of embryo. This results from the programmed sequential action of progesterone on a estrogen-primed endometrium. What is displaced window of implantation? Presence of endometrial markers at an inappropriate time of the cycle by the action of progesterone on estradiol-primed endometrium, leading to abnormal development of the endometrium, preventing embryo implantation. This is a displaced window of implantation. I'll explain this better. Now, here, please remember, window of implantation could be a period of 1 to 2 days to even 3 days. Now, how does 1 and 1.5 day or 2 day make any difference? These are questions which come to my mind when I talk about. Now, what is defining RIF in ART? Now, here also from a whole given population who's undergoing IVF to we come to now individualized RIF. The ESHRI working group of RIF 2023 recommends considering RIF as a secondary phenomena of ART, as it can only be observed in patients undergoing IVF. And to address the ambiguities in the definition to date, it is recommended that the following description of RIF be adopted. What is the description of RIF? RIF describes the scenario in which the transfer of embryos considered to be viable has failed to result in a positive pregnancy test sufficiently often in a specific patient to warrant consideration of further investigations or interventions. Now, what does this mean? This ESHRI working group for RIF 2023, they said someone has gone through basic fertility workup and you've done IVF and you've done at least 2 embryo transfers which failed to result in a pregnancy. Now the patient will definitely come to you, do cycle fail ho gaya, what to do? Now consider the cumulative chance of having achieved an implantation to date in that particular patient. What is her age? What is her reserve? What is her BMI? Look at all these. And also you have to look at your own center. What are the pregnancy rates of your center? And not just pregnancy rate, you have to look at the implantation rate. So if you have 2 blastocyst failure and your implantation rate is 20% of one blastocyst, she doesn't come into the category of RIF. It is 60% is the cutoff. When you think that 60% she should have got pregnant because your implantation rates are 50%. So 2 embryo transfer gave her a chance of more than 60% to have an implantation or pregnancy, which did not happen. So if she had a chance of more than 60% looking at her age, her BMI, the condition of the embryos, then you suspect RIF. But if her cumulative chance of implantation and pregnancy was less than 60 in the 2 embryos which failed to implant, then you proceed with another ART cycle and you do another embryo transfer, whether you pick up the eggs again or you have embryos from this first cycle. So this is how we go about it. And this is a very crude estimation of how we go through a cycle. How do we make an estimation? So there are IVF predict calculators are available from Nelson and Lawyer model, which you would find at ivfpredict.com to predict chances of pregnancy in a particular patient undergoing IVF. But what they say is, will there be some women who might be now, there are some centers. What is the benchmark of implantation? It is almost 60-65%. So any IVF center which has reached the benchmark of implantation, in a young woman, you've implanted one morphologically grade AA embryo, then you say, oh, her chance was 60% of implantation and she failed. So is she RIF? No. If some woman who might be expected to have a 60% chance of implantation after just one embryo transfer, yet the minimum number of identifying implantation failures to be called as recurrent should be 2. So, here what they took out is that suppose you do your own workup first. Please be honest with your workup and you see in less than 35, 35 to 39 and more than 40, what is the implantation rate or pregnancy rate if you transferred one embryo, maybe day 3, and you look at implantation rate of day 5. And once you know that your implantation rate was in less than 35, it should have been 31%. Then you know that in the third ET, her implantation would have exceeded 60% and it has failed. So you will intervene after 3 ETs. Now, if her age was 35 to 39, you yourself would calculate and you would find that implantation goes a little low with age. Her chances of implantation were 25.9. Then you find at the 4th ET, she exceeded 60% chance. She should have exceeded 60% chance, but she failed. And therefore, you will intervene after 4 ETs. And a woman who is more than 40 years old and her implantation rate or pregnancy rate is 15% only, you will see that she reaches the 62% after 6 ETs. And hence, for her, the individualized RIF would be after 6 ETs. So it is so interesting to see that like we have individualized COS and we have individualized embryo transfer, we also define RIF and individualized RIF according to what chance she had in which center. It is your center which will calculate your chance that in so many FETs, if she did not, or fresh or frozen transfers, she did not conceive, then she needs investigation about FET, because investigations are so difficult. There is no such investigation which can pinpoint and say, oh, she has RIF, give her this treatment, you will succeed. No, it doesn't happen that way. But if it is a euploid embryo across board, less than 35, 35 to 40, more than 40, you see that the intervention comes after 2 first FET. Means she has a greater chance, almost 60% chance all across ages, because these are euploid embryos. So, but we cannot say that after the first ET only, we will start investigating her for recurrent implantation failure. She has to have two ETs failed, and therefore intervene after two ETs, intervene after two ETs, and intervene after two ETs is what is said, that in euploid embryos, you have to intervene. So I just took this little time to explain RIF and what this is. What is window of implantation? The embryo smiles, reaches, and the window is open. What is closed window of implantation? The embryo reaches and finds the window is already closed, doesn't know what to do. It has not opened or it has already closed. That we find out by test. So this is how the jigsaw puzzle has to fit in. For that, ERA test has been described, and that is why the largest ERA study, which was published in 2019, said that first IVF does not predict implantation. ERA does not predict the first in the first IVF cycle, ERA has no predictive value about implantation. It is only in recurrent failure. So it looks at 238 genes involved in endometrial receptivity, and it is a microarray assay that quantifies the expression. It just looks at the quantity that all these genes are there or not. So it is a personalized genetic test to diagnose the state of endometrial receptivity in the window of implantation. So when you take a biopsy is the time when you were putting the embryo in, and whether it is natural cycle or frozen cycle. And if that biopsy says that all the 238 genes are present and this endometrium should have been receptive, then it will come as normal ERA. But if they say all have already been closed, then it is a post-receptive one. And if they say they are yet to open, then it is a pre-receptive endometrium. So it tells you the ideal time of WOI since the day of progesterone exposure for embryo implantation in that particular HRT cycle. So this is how ERA report is generated. You see first the proliferative stage is there, then you give progesterone. This is the pre-receptive stage when you are going on giving progesterone. And then comes the window of implantation, which opens up, and then comes window of implantation is closed after maybe 7 days of progesterone, and it becomes post-receptive. So this is the window of implantation after analyzing all the genes, that is 238 genes. And this becomes a pre-receptive, this is post-receptive, and that is receptive. Shortcomings of ERA are cannot histologically date endometrium or identify pathological endometrium. So it can only tell us window of implantation. Two is similar pregnancy rates in ERA performed and non-performed. Some people have done randomized trial. Very few people had the courage to do a randomized controls trial, which meant that ERA came pre-receptive, yet you did not listen to ERA. You transferred the embryo in the same HRT or natural cycle with the same exposure to progesterone in one arm, and in the other arm, you did a ERA-derived transfer and you found pregnancy rates were similar in both groups. Then inconsistency in biopsy dates in natural cycle versus artificial cycle. This is a very important question which comes to my mind when we look at LH surge, and then we look at progesterone rise. It actually should date with the LH surge. However, I feel that after the LH surge starts settling, the progesterone should rise. And if there's no progesterone in the circulation after the LH surge started coming down, I feel a little insecure thinking that I would count this as day one. And then window of implantation, naturally, it has been described by Georgina Jones that it spans for 2 to 3 days. So how slight change in progesterone can change the WI? Why will it not extend to the 6th day, or why will it not start from the 4th or 4.5 days? So these are the questions which come with ERA into my mind. And another question which I have not written here is, if ERA is done today and one comes for transfer after 6 months, will ERA still hold true, or would the genetic profile change? Or if one comes after a missed abortion or pregnancy, does that ERA again hold true for her, or it would change? So there are questions with ERA. It is not an absolute test. So we have to still put our minds to it. Last is previous ectopic in an IVF cycle. This is a very, very large study from China, 30,000 cycles. They looked at is frozen embryo transfer cycle associated with a significantly lower incidence of ectopic pregnancy? This is analysis of 30,000 cycles. And what they found was that the incidence of ectopic pregnancy per clinical pregnancy was 4.62 for fresh transfer compared to 2.2 for frozen thawed cycle. And remember, the numbers are great, and therefore statistical significance was there with this change in percentage. Fresh ET cycles had highest risk of ectopic pregnancy, followed by day 3 frozen cycles, followed by blastocyst frozen embryo transfer cycles. So what was the gist of all this? That frozen embryo transfer, blastocyst transfer cycles had lowest risk of ectopic pregnancy, and all the differences were statistically significant. So we feel that if somebody had a ectopic on an IVF pregnancy, we're not talking about natural ectopics, but in an IVF, then it is best to freeze all the embryos, make blastocyst, and transfer a blastocyst. Having said that, the conclusion is um, oocyte and embryo donation model was the first example of individualization of embryo transfer with donor and recipient being prepared simultaneously to synchronize OCR and ET. The purpose of individualized ET is to safeguard the woman's health on one side and optimize her chances of pregnancy on the other side. This took birth after the successful vitrification of embryos. The policy of freeze all and subsequent ET started as a strategy to prevent OHSS in 2012 with the OHSS free clinic concept of Paul Deveroy. Segmentation of cycles has been extrapolated to numerous indications now, such as presence of a polyp at OCR, thin or thick endometrium on the day of ET. These are and means to circumvent medical and surgical emergencies and to be able to postpone embryo transfer in cases of progesterone rise on the day of HCG during COS. In true cases of RIF, there is an option to investigate genetic endometrial markers and treat the woman appropriately before individualized and embryo transfer can be done to optimize success. Thank you. So education is not just the learning of facts, but the training of mind to think also. Very important to think, why is it not working? Why does progesterone rise lead to asynchrony of the endometrium? Because in a frozen cycle, we don't even think of giving 7 days of progesterone. So in a fresh cycle also, it will not work. That is the end of my talk. And now we are open to questions. I'm sorry I took longer because I explained RIF and its definition.
You all can put your questions in the chat box. Dr. Priya wants to know progesterone support after fresh versus frozen transfer. Any role of adding estrogen in fresh transfer? And what about support after fresh transfer with agonist trigger?
See, Priya, support, first I'll answer the last question. After agonist trigger, in any case, there is a heavy chance of utolysis. And hence, you need extensive support. You really need a very strong support. So estrogen also, because when utolysis happens, everything is gone. Estrogen is gone, progesterone is gone. The receptors are gone, and the cytokines destroy the endometrium. So one is we have to prevent lysis. So small dose of HCG is important, and you give estrogen and progesterone both. Now we go to your next question, the role of adding estrogen in fresh transfers. Once upon a time, we would add a small amount of estrogen in the earlier days, but not anymore now. Why? Because we thought that, say estrogen levels were 2000 on the day of HCG trigger. And we picked up all the eggs, made embryos, and we saw that in some cycles, estrogen fell very drastically. And we thought maybe this is the reason we failed in having a pregnancy. So we started giving a small dose of oral estrogen to these women in the luteal phase. But now all these studies are over, and they have diffuted this fact that we need any estrogen support in a fresh cycle, because we do not transfer in hyperstimulated cycles. We do not transfer in cycles where we know that progesterone is high. If you don't know progesterone is high, you may transfer and you will fail. It will go as one of your failures, and you will never know the reason because we never saw the progesterone. So in cycles where you are contemplating a fresh transfer, progesterone is more important. They should not be hyperstimulated cycles. Don't transfer in hyperstimulated cycles. You will never need estrogen. And as far as frozen transfer is concerned, it is best to drop the estrogen dose a little when you start progesterone, because that is what happens in a natural ovulatory cycle. The estrogen always drops a little after ovulation.
Any other questions? Dr. Mansa wants to know, is there any explanation as to why there is lower risk of ectopic following frozen transfers?
I really don't know, Mansa. I want you young people to do research on this, because you see, we are doctors only when our mind keeps working. The training of the mind to think is important. You've thought of such a good question. Work on it, because all we could do is what the Chinese did: 30,000 pregnancies analyzed, which were caused by IVF fresh and frozen transfers. And they did all ectopics. And they must have seen all ectopics over maybe whatever period. And they looked into how many IVF cycles had to be done to create those many ectopics. And they went back and said that, yes, the risk of ectopic is lower in a frozen transfer. What I feel in a frozen transfer, blastocyst transfer, is most of the time when the embryologist is giving us the blastocyst after thawing, says it's almost hatching. So if the endometrium is appropriate and you've put in a hatching blastocyst in the cavity of the uterus, not very high that it could just turn into the cornua of the uterus, then it is already hatching. So it doesn't have very far to go, because it will have to find the receptors of the endometrium close to it, and it will go and combine over there. And therefore, blastocyst transfer gives us the lowest chance of ectopic, because the embryo doesn't keep rolling to find the appropriate place. In day 3 transfers, it will still roll for at least 48 hours, maybe a little more, till it becomes a blastocyst inside the uterus and hatches. And in that process, it can roll up to the tube and cornua. So fresh transfers, I don't know whether blastocyst transfer, why does it lead to more ectopics? But in a fresh transfer, I would only say there are so much cytokines over there by ovarian stimulation, by ovarian injury. There are a lot of inflammatory markers, and hence the uterus might be more contractile in a fresh transfer. But I'm just thinking about it. When you ask the question, I don't know the answer why fresh transfer leads to a higher rate. But frozen, I can just tell you that yes, blastocyst will be better than day 3, because it will hatch very soon after your transfer, and the embryo may not have a lot of time to keep rolling in the uterine cavity to find a place to do implant.
Dr. Nitika wants to know, is there any role of GnRH agonist in previous cycle when planning for FET?
You know, in cycles where you find a high E2 on the day 2, I have some cycles where the E2 doesn't come below 200 or 100, 200 on the day when we are starting the transfer. Maybe these are the cycles where you might want to give, or cycles where you found a progesterone rise before starting, in HRT cycles before starting progesterone, which now has become a headache for me. And I've thought that I will do progesterone on all HRT cycles to make sure that the progesterone is not elevated. And if it is elevated, then giving Lupride depot or maybe Zoladex could be a good option before FET, but not in all cases. In endometriotic cyst, I do not give unless the E2 is playing tricks with me, or the progesterone is playing tricks with me on day 2 or on day of starting progesterone, both places.
Dr. Priya wants to know any role of progesterone levels before the day of transfer. If yes, then what is the cutoff?
See, when you're talking about a frozen transfer, Priya, then Bhavani will be able to tell you what is the effect of progesterone in a case of frozen, because her whole paper which got published was on this. Bhavani, tell us.
In the study we did, it was while using vaginal progesterone in FET cycles, 400 milligrams, and we checked the serum progesterone twice a day, and we checked serum progesterone on the day of embryo transfer, and we found a cutoff of 8 nanogram to be predictive of the ongoing pregnancy rate. So more than 8 was found out to be optimal in the study. But this was while using vaginal progesterone. So the cutoff varies depending upon the route of progesterone. So if you are using
So did you get
intramuscular,
any pregnancies in less than 8 nanogram also on the day of embryo transfer?
yes, ma'am, pregnancies were there, but there was a significant difference in the ongoing pregnancy rate between less than 8 and more than 8.
So which was the lowest progesterone in which you got a pregnancy which went into live birth?
Ma'am, I think it was 2 nanogram.
So see, this is where individualized matters come in. And vaginal progesterone always has low serum level. So the moment you give injectable, the serum levels will go up. So I don't know, it's just a virtual satisfaction that serum levels have gone up. What we need is at the endometrial level. So giving injectable doesn't tell us that endometrial level also the levels have gone up, because if you see at older studies, they've seen the implantation is same, but with injectable, the serum levels were higher. With vaginal, the serum levels were lower. So your answer is done, Priya? You're okay with the answer? And one day before embryo transfer, a lot of people are doing one day before also. But do you think what we found was the level of progesterone is important, but high levels don't harm? And if one day before you find a slightly lower level, you have one extra day where you can give progesterone. But will this help? Vaginal will give you the same results, and injectable will give you a virtual high of progesterone. Ma'am, does LH level prior to starting progesterone in HRT FET cycle affect? No, I don't think LH levels should. And why will you do LH levels? I mean, I don't know if LH levels before starting, because I've never done it. And I've never read also that LH levels in a HRT cycle would have an effect. Because the moment you give HRT, FSH, LH, both should be suppressed. Galaxy went to start progesterone in fresh transfers on the day of OCR, a day after, maybe 2 days later also, because we don't want very rapid increase in progesterone. And if you read papers, they also say that when progesterone was started 1 to 2 days later, they had better pregnancy rates rather than starting them on the day of OCR only. Do you give Lupride, Depo, Zoladex, ye ho gaya, and FET day 3 transfer, which works best? Same day Thoin transfer? This is a very good question. If you have enough embryos, then I would say you can do same day thaw, and if you have less embryos, same day thaw and transfer. But if the patient has failed multiple times on day 3 transfer and you have enough, you have 2 day 3 embryos, see why is she failing, and then in that case, it is good to extend culture and take them to blastocyst. But if there has been no difficulty, please do them in day 3 only. There is a difference in pregnancy rate. In my lab, I know that day 3 embryos have an implantation of about 30%, and day 5 has an implantation rate of about 58 to 59%. So I would, if it is day 3, I would want to transfer 2 embryos to reach an implantation rate of over 60%.
And there's a question.
Sequential transfer, I think I will never recommend anyone to do or to have it for their relatives, because it only shows the loss of confidence of the person who's putting the embryo in, that he doesn't feel confident about the day 3 embryo which is put in, and there is a high chance of multiple pregnancy. So I don't think that I would ever want to do or resort to sequential transfer. But I would want you all to bring out papers. A lot of people do it, but this just shows the lack of confidence of the operator that day 3 में 2 डाला, फिर day 5 में या 6 में एक और डाल दिया, which I feel is not a very, it just reflects your loss of confidence to all other people. Enough?
Ma'am, last question. Someone has asked, do you give Lupride Depot or Zoladex before FET in cases of endometriotic cysts and adenomyosis?
Yeah, I just said that this depends on if implantations have failed or the uterus is really large in adenomyosis. then I would give it, but not otherwise. I just do the first transfer without giving anything if the size of the uterus is all right. Size is not too large, 8 centimeters, at the most 9 centimeters. But yes, if two embryo transfers have failed, I would definitely want to give one of these, and I would not give it just for 1 month. I'll give it for 3 to 6 months to bring the uterus size to normal, which means 100 cubic centimeters, and then do a transfer. So anything else? Is Tejashri there?
Yes, ma'am, I'm here.
Yeah, I wanted you to, did you attend the whole lecture? I was looking for you in the beginning. No,
Little
not you
caught
were
up in the OPD, ma'am, so
yeah.
missed
So
out on
I want you
major
to go
parts.
through this when it goes on
I
the
will do that.
website of the YouTube,
Absolutely.
because I answered your question of personalized embryo transfer and individualized embryo transfer in that little
Right.
difference which you highlighted into my mind. I never thought that these were two different things, but I feel that they are similar. But yes, when we talk about
Hmm.
personalized, then it is also for RIF included.
And following the ERA test. So I always thought
Following
that
the ERA
personalized is
test.
personalized
Yeah,
to that
yeah.
particular patient,
Because this
depending on
word,
their
yeah, this word has been coined by the makers of ERA only,
ERA.
personalized
Yeah.
embryo transfer.
Right, ma'am.
But otherwise, if an exam question comes, then I think individualized and personalized, you'll have to write all what I said in
Right,
the
ma'am.
talk. You will have to
Ma'am,
include
I'm so
that.
sorry to have missed out on major part
No,
of
you
the
will get
talk,
the
but
whole thing. And there are
did you talk about the natural cycle FET, or we are going to do that next time, ma'am?
that is going to be a separate talk. I
Separate talk.
was
Oh,
only
all
talking
right.
about individualized embryo transfer, where you do
Right.
fresh one, where you do only frozen, where you would do only single. So these are three very important strategies which we all
Yeah,
have to follow.
decision. Yeah.
Yes, said no to embryo transfers in patients who are at risk. No fresh transfer where there is a risk of either the woman's health jeopardy or the pregnancy rates being low. And
Right.
there are certain indications where you would only prefer frozen transfer because of whatever reasons are there. All right?
Absolutely. We are waiting to hear from you about the FET preparation and the natural
Yeah,
cycle
I'll have to
transfer.
make a whole preparation for that. I'll make it. Okay, thank you
Thank you so
everyone
much,
for
ma'am.
joining. Thank
Wonderful
you.
as
Thank
always.
you.
Thank you.
Thank you, Bhavani. And
Thank you, ma'am.
I have to thank my mentor for this, the whole INTAS team who's there.
Thank you, ma'am.
Thank you so much for always being there. And
Thank you, ma'am.
Dave, you are
Yes,
still
ma'am.
there. I think you are enriching yourself
Yes,
on
ma'am.
so many topics. Thank
Yes.
you. Okay,
Thank you,
thank you.
ma'am.
Manas is there also, I can see. Manas is there? No, he's not there today. So I can see a lot of people there. I'm happy that all the IVF girls have joined in, but Tarang Yadav is probably sleeping a little bit. Lovely. Thank you so much. Bye.
Thank
Good
you. Bye.
night.
Good night. Host, you can support. You can end the meeting.
Yeah?
No, I'm telling the support team. Support team, you
Yeah.
can end the
End the
meeting.
meeting. Yes, please.